What we're going to do is give you a short introduction on what prognosis reviews are, including then going through the steps of a prognosis review, and also then at the end, the Cochrane tools and guidance that is currently yet available. I will do the first part indeed, and Anneke will take over after my first part. Indeed, the next slide. Yeah, and I'm very happy to say this, to announce this. We already, as a Cochrane Prognosis Methods Group, we already developed a lot of material which is available, as you will see the link at the end of this talk, available at the end of this lecture, indeed. And so the guidance that we provide is already largely in the air, so to say. Only we are now compiling it to the new, as you might have heard, Cochrane Handbook. Will be the fourth Cochrane Handbook, if I'm correct. We have it of interventions, we have it for DTA, qualitative reviews, and this is the fourth. And we are planning, and I'm almost sure we make it, that we launch it at the next Cochrane Colloquium, which will be in India in October 26. So we are very eager to do this. At the end of this year, we probably have it done. Next slide, please. And next slide. So why systematic reviews of prognosis studies? Well, as I often say, and of course, arguably, but the majority of maybe even of the audience, but even of the world is probably exposed to systematic reviews and meta-analysis of randomized intervention studies, therapeutic intervention studies. And then subsequently, of course, we embarked on systematic reviews and meta-analysis of diagnostic test accuracy studies. But my hunch is that you ain't seen nothing yet if you are very familiar to that field, because on prognosis studies, I think almost the majority of current publications in the literature is very, very much on prognosis, somehow on prognosis. I will abbreviate shortly in the next slide what type of prognosis studies we mean then. No, sorry, first the previous slide. And why is this increasing interest so big? Now, first of all, almost every minute, and you can actually check it yourself, if you plug in the word biomarker in PubMed, almost every few minutes, a new paper erupts. And it's usually a biomarker for some prognostication, for some disease or for some outcome. And the number of prognostic models is in the thousands, in the tens of thousands, some people say in the 100,000s even. And what I also see in the current era of AI, artificial intelligence, and machine learning, that almost everything is repeating what we did before, because we can. Because so many new models are developed, which actually aiming to replace existing models. And for some areas that we have indeed more than hundreds or even thousands of prediction models for the same disease and for the same outcome. So the number of primary prognosis studies is hugely increasing. And I'm afraid, again, as that will only further increase in the coming era. So that means, since we have hardly any time to read anymore, and the only thing we read is probably social media and TikTok to stay, and the short news flashes to stay alert and up to date, is let alone that we are going to read all these primary studies on therapeutic studies, DTA, and prognosis studies. So reviews of prognosis studies is highly desired, not only by us, but also by practitioners, guideline developers, journals. And as I said, certainly given the steep rise of primary prognosis studies, also due to AI and ML, we have to embark even more than we did now on how to do reviews of these primary studies. Now, that's all the good news. The bad news is that randomized trials on how to conduct them is already out there for decades. Some say even for hundreds of years, but let's at least say for 80 years. I think one of the very first published RCTs was, of course, the streptomycin trial in the BMJ, British Medical Journal at that time, 1948. So there's much more guidance already out there and knowledge and expertise on RCTs, both on primary side and on the review side. And there's also usually a very narrow and focused design and analysis of such studies. With prognosis studies, there's much more variation in types of questions, in the use designs, in the use effect measures, in the use statistical analysis. So the challenges are bigger. Now that's the bad news. The good news is that a lot of people around the globe have developed increasingly templates and guidance for the different steps of how to do a review of prognosis studies. But it ain't easy because we came further down the road to develop these. Next slide, please. Yep. Now, what is prognosis? Prognosis, actually, it's in the word. It means pre-knowing. Another word is predicting, is pre-telling. It's all the same word, pre-knowing, come from Latin and from Greek and Latin. It's actually forecasting, pre-telling, pre-knowing the future course or the future outcomes in an individual in a certain health state. We are very explicit in also in the handbook that we are going to write, that we are writing, very explicit. You don't need to be sick to have a prognosis. I know. I'm also coming I'm also working in the medical field in a medical hospital. Prognosis, we usually typically assign that to people with a certain disease, but you don't need to be sick to have a prognosis. You and I, we all have a prognosis, but on anything, a prognosis of developing some disease, a prognosis of dying, even, by the way. And the young people have a much better prognosis on dying, a lower probability than I have, simply due to my age. So prognosis, people who are women who are pregnant have a prognosis maybe to develop some disorder during pregnancy, and pregnancy is of course not a sickness. So we are very explicit, and the Cochrane Prognosis Handbook also addresses all types of prognosis studies. Simply everything where we are forecasting some outcome in individuals in a certain health state is considered in the handbook. So a more technical definition of prognosis in the literature is the probable or the prediction of specific future outcomes in subjects with a certain health condition or within a certain health state. And the reason why people have done this in the literature is because a disease does not necessarily have a prognosis, but it's actually an individual with that disease that has a prognosis. So if you think as a doctor of the prognosis of myocardial infarction, it's actually a strange thinking. It's rather a particular male or female or any other type of person that has a particular age, a particular history, a particular symptoms and signs that might have a presence or a future occurrence of myocardial infarction. And that's something else than simply the prognosis of myocardial infarction. Next slide, please. Now, why do we prognosticate? I think this is clear to most of us, is simply to provide information for counseling to patients, clients, individuals, to identify groups for treatment or other lifestyle management, simply to make lifestyle or management or treatment decision, including no management at all. Epstein is also an important decision in medical care, particularly on ICUs, of course. To target specific prognostic factors, to find specific prognostic factors that might modify treatment effects, to select high or low risk patients for inclusion in RCTs, for example, and also, not unimportantly, to adjust for case mix differences when we are comparing healthcare institutes. Next slide, please. Now, what are the types of prognosis studies that we cover, particularly also in the handbook, is primary studies that address the overall prognosis, the average course or the average outcomes of individuals within a certain health condition. That's one type of studies we address. Prognostic factor studies, that's probably the majority nowadays in the prognostic literature, is that are studies that are trying to identify which factors are associated with a specific outcome over time in individuals with a certain health condition. And the other one is prognostic modeling studies, the third one. Prognostic modeling studies is not the same as two, but it's really something else. And that's rather studies that are trying to develop a tool or an algorithm, if you like, of combination of prognostic factors to illustrate and to quantify how well that combination of these factors can predict the future in individuals within a certain health outcome. With a certain health condition to predict a certain health outcome. And these prognostic models need to be developed, they need to be tested in other individuals, and then they need to be applied. Indeed, the next slide. In this lecture, we simply have to choose some messages. We are going to elaborate a little bit on two kinds. The two most frequent kinds of prognosis studies in literature is indeed prognostic factor studies and the third prognostic modeling studies. Next slide. Now, again, what are prognostic factor studies? Primary prognostic factor study is to identify which factors are associated with subsequent outcomes in subjects with a certain health condition. And again, I mentioned it, not necessarily sick people, it can also be done in healthy individuals. For example, the Framingham risk model, one of the most famous prediction models also in clinical practice. In the prognosis literature, was not done in sick people, but simply people who were living and alive in Framingham in 1948, I think, when the cohort started. And those studies try to find not only the crude association of factors with outcome, but typically also the independent or adjusted association of factors associated with a specific outcome. Next slide. So a very nice example. You can think of a cohort of patients that are diagnosed with rheumatoid arthritis. They can enter a particular study. So if that is the light blue circle is the total target population, source population of those adults, somebody can do a study sample, a random sample of that source population in some institute or some country, and they can be followed up over time to see whether, to what extent, for example, within a year or 2 years, develop functional disability. That's then the outcome. And there are, for example, quite a lot of studies done to see whether the factor joint damage that is measured at T0, when the study sample was formed, when somebody enters the cohort, whether the prognostic factor joint damage is indeed associated to functional disability a year later. So this is a typical prognostic factor primary study, and then this example shows you that they are only focusing on the prognostic factor joint damage, but you can also imagine that they could have studied the effect of gender, the effect of age, the effect of family history with rheumatoid arthritis. All other prognostic factors are typically considered in the same prognostic factor study. Next slide, please. Now, having explained what a primary prognostic factor study is, then what are the prognostic model studies? Next slide, please. A prognostic model or an algorithm or a score, it's all synonyms typically used in the literature. There are so many synonyms for the word prognostic model or prediction model, unfortunately, and I cannot help that. But what it typically is, a model or an algorithm, is a combination of at least two predictors that are combined in some kind of algorithm or formula or software that convert predictor values into an absolute, that's important, an absolute probability of either the presence of a disease, that's called the diagnostic prediction model, or the future occurrence of a certain outcome, and that's a prognostic prediction model, which is the focus also of today. Now, a prediction model is typically developed for use not in the people from which the model is developed, but of course for use in new individuals that were not used for the development of the model, but for new individuals, new patients in other practices, other countries, to estimate their individual probability of the outcome. And here the focus is not so much on the extent to which a single factor is associated to an outcome, but rather to the extent the entire model can predict the outcome. And it's very different from the previous type of studies that I just illustrated. A prognostic model is the model under review, and in a prognostic factor, it's the factors that are under review. Next slide. Now, there are typically 3 phases, and why we explain this is because it also depends on the type of review you do, as we will show you a little later down this webinar. The 3 phases of prognostic modeling or prediction modeling, sorry for the typo, it's modeling and not modeling, of course. First of all, the models need to be developed, and a model development study is simply a study where a data set is used, where predictors were measured and the data of predictors were collected in individuals. Also, the outcomes were were measured, and then some statistical analysis is used. Regression modeling, a time to event modeling, or a random forest, or an XGBoost. All machine learning methods are used for this type of research as well, to develop a model to identify which are the important predictors, estimate the weights of these predictors related to the outcome, and to what extent such combination of predictors, which is the model or the algorithm, indeed predict the outcome of that entire model, not of the factors, but of the entire model. Now, a subsequent study usually is undertaken, at least that's usually what is advocated, to check whether that developed model in other individuals actually also accurately predicts in new individuals. That are the model validation studies. And then 1 and 2, of course, is needed, but the ultimate proof, what's the saying again? The proof is in the eating of the pudding, is the model impact studies. And model impact studies are actually are comparative studies, are more or less intervention studies. Is a comparative study where one group of, for example, physicians or individuals use the model and superimpose management based on the predictions by the model. So actually you have an index group where the model is used, including the subsequent treatment decisions or management decision, as compared to a control group where that model is not used. And if the model is indeed having some impact, you expect that the management in the index group with the use of the model is different, and the outcomes are different than the management that is used in the control group where the model is not used. Now, the big difference between 1 and 2 versus 3 is that 1 and 2 are not comparative studies. 1 and 2 are actually single, more or less, cohort studies, and 3 is a comparative studies. So, and indeed, ideally, those are randomized comparative studies, randomized trials. Now, the handbook, what I need to say, and everything what we have addressed as the prognosis methods group is concerning for prediction modeling studies type 1 and 2, and not type 3. For type 3 type of prognostic model studies, the comparative studies, we refer to the Cochrane Handbook of Intervention Studies. We stay away from that field because that's more a comparative randomized study than it is a prognostic model cohort study. Next slide. Now, I hope I haven't lost you with this introduction of primary prognosis studies with a focus on prognostic factor and model studies. So what are now the steps? A few more slides I have to present before Anneke takes over. Now, here are the well-known steps, I think, of a systematic review, including of a systematic review for prognosis studies. We need to formulate a review question. We do that with the PICOTs. We need to search for studies. We need to screen and select the articles. We need to extract the data, do risk or bias assessment, synthesize the whole thing, and of course, interpret, grade, and draw conclusions. Next slide. Next slide. Now, the well-formulated review question, the best guidance that we can give you is that we use the CHARMS checklist, and the CHARMS is a paper that has been written quite a while ago. It was actually developed for critical appraisal and data extraction for systematic reviews for prediction modeling studies, as well as guidance how to frame a review question for prognostic models. However, Richard Riley et al. Also transformed the CHARMS checklist also for framing the review question of prognostic factor reviews. So the best guidance we think we can provide is if you do a prognostic factor review, then use the CHARMS checklist for developing your PICOTs. I'm going to show you what a PICOTs is using the paper of Riley et al. And if you want to do it for prognostic models, use the paper of Dubreuil et al., which are at the bottom of this slide. Next slide. So what is the PICOTs? I think it's actually a little extension. I'm sure it's a little extension of the PICO. And very quickly, what it is, it's the population. The P stands for the population. So what is the target population in which the prognostic factors might be used in practice? What are the index prognostic factors that people are interested in? Are there also comparator prognostic factors that people are interested in? What are the outcomes that are actually aiming to be predicted by those prognostic factors? And then the timing, we added two aspects in the prognosis reviews. There's the T and the S aspects to the PICO. The timing has two elements. First of all, at what time points are the prognostic factors to be used? And the second element is actually the prediction horizon. Over what time period are we predicting the outcome? Predicting something in the next week is, of course, very different and maybe easier, arguably, than predicting something in 10 years. And the setting is the intended setting, the intended role, the intended context of the prognostic factors. For example, is it primary care? Is it nursery care? Is it home care? Is it secondary care, tertiary care? Because we know that prognostic factors have a different predictive accuracy in the different settings. Next slide. Now, this is the same PICOT. This is an example how the PICOT should be formulated if you do a review on prognostic models. The previous one was on prognostic factors. So again, it's the same thing, the same rhythm. What is the target population in which the prediction models on the review will be used? What is the index prediction model is the focus on a specific model. For example, the Framingham model or the Wells model or the Nottingham risk profile, or is the interest also in other existing prediction models? Are there comparator models to be studied in your review? What are the outcomes you are predicting? And then the same T and the S as in prognostic factor studies. Next slide. Now my last two slides. There are many reviews on prognostic model questions, and I just show you a few that are all covered in the handbook and is all covered in the guidance that is currently available on the Prognosis Methods Group website. One can be very interested in reviewing all models, prediction models, for a specific outcome in a specific target population. So just two examples. People were interested and actually wrote a review, actually more than one review. All models predicting fatal or non-fatal coronary heart diseases in middle-aged general population. And I recently saw that there are more than 1,000 models actually have been developed for this purpose. It's almost ridiculous if you think about it. Or models that predicting this for survival after cardiac surgery. For example, predicting length of stay after cardiac surgery or predicting quality of life after surgery. So people are simply doing a review to see which models are developed in this field and also how many of them were validated. You can also review all existing models in a particular clinical field. For example, people have evaluated all models for any cardiovascular disease outcome in the general population. Or there are a few reviews on all developed models in obstetrics. Big reviews, we probably might consider them as type of scoping reviews, but they are very hot currently also in the literature, and they usually are very well received by journals. Next slide. What you also can do is focusing on a specific model. For example, how good is the predictive performance of a specific model for a specific target population? And every model is developed only once. Like every drug is constructed or manufactured only once. Every test is developed or manufactured only once. But of course, there are multiple randomized trials on the specific drugs that can be done. There can be multiple diagnostic test accuracy studies on a single test be done. And so there can be multiple validation studies of a specific model that is developed only once. And then you can also do a meta-analysis of the performance of that specific model across the various included validation studies. And also, it's also a very interesting field is the fourth type is the review on the added predictive value of a specific predictor when it is added to an existing model. A famous one was in JAMA is to see whether CRP should be added to the existing Framingham risk score. That's a very interesting review or meta-analysis that has been done, I think, by Joanna Tsulaki et al. Or should we add the D-dimer test to the Wells rules?